I'm Dr. Savitri, and I'll be presenting my paper on algorithmic approach for planning implantable colamer lens in keratoconus. At the outset, I would like to declare that me and my co-authors don't have any financial interest. So, to begin with, we all know that keratoconus induces myopia and irregular astigmatism. It decreases the quality of vision due to irregular corneal curvature, high order aberrations, etc. So, collagen cross linking is a modality to arrest progression. When it is combined with the laser based cross linking and or the ICRS, it does confer stability to the eye, but at the same time, the visual quality and quantity is compromised due to the residual refractive error. So, what are our options? So, the patient can be given glasses or contact lens, but then these come with their own set of limitations as highlighted here. So, a phakic IOL is routinely used for refractive error correction in myopia or hyperopia. The advantages it offers is that it is reversible, it corrects high refractive errors, it is well tolerated, and it gives freedom from the daily hassles of contact lens. We did a quick review of literature, and there are multiple studies showing the use of toric implantable colamer lens in keratoconus for the primary correction of refractive error. We found out that it is highly efficacious. There is high safety and predictability according to these studies. So, despite these established facts and figures, we were left to question ourselves if we can make the refractive outcome with phakic IOLs more predictable, or if we can improve the visual quality in complex corneas, for example, having high irregular corneas or decentered cones. So then we had to find answers to our research question. So was such kind of IOL suitable for all kind of KC eyes, or can we have an algorithm for planning phakic IOLs in keratoconus? We did an extensive clinical workup, and all patients were thoroughly examined clinically and imaged on various diagnostic machines. Then when can we plan the phakic IOL in KC? So patient having stable refraction and topography with clear central cornea, having contact lens intolerance, or if the patient's quality of life is significantly affected, these kind of patients can be taken up for phakic IOL. In the virgin eyes, we have to make sure that there is a documented tomographic stability for 2 years. Whereas if the patient is having a highly aberrated cornea, we first have to plan a laser based cross linking for regularizing the cornea, or if the patient is having decentered cone, we first have to plan an intact or for the cone centration. At the end of everything, we have to make sure that stable topography and refraction is there at two time points 6 months apart following cross linking, and then we can go ahead with the phakic lens. The aim of our study was to develop an algorithm for planning implantable colamer lens in keratogenic eyes. So we undertook a retrospective observational study at our tertiary eye care center, wherein we included 35 keratogenic eyes of 21 patients. The patients having stable KC, centered cone, clear central cornea were included in the study. Also, we do a RGP trial for these patients, and we check if the preoperative CDVA is comparable with the RGP contact lens CDVA. Whereas on the other hand, patients having unstable KC, decentered cones, scarred corneas, and active allergy eye disease were excluded. So what we found out was that Intax was inserted in 14% of the eyes having decentered cones to begin with, which was followed by TICL implantation. 10 eyes having high HOA along with 15 eyes, that is 43% of the eyes having contact lens intolerance, were first subjected to a laser-based cross-linking followed by DICL implantation. The preoperative mean refractive spherical equivalent and the preoperative mean cylinder was found to significantly reduce when we checked them at 2 years post-procedure. The preoperative uncorrected visual acuity distance for the distance vision, it improved significantly post-operative. Also, we found that for the best corrected distance visual acuity, there was no loss of lines in any of the eyes. 18 eyes showed no change, whereas there was gain of 1 line and 2 line in 11 and 6 eyes respectively. The efficacy index was found to be 1.16, and there were no intraoperative complications or adverse events during a follow-up of 2 years. So based on our cohort, we devised an algorithm for planning ICL in KC. First, we check for the cone position. So if the cone is centered and the KC is stable for more than 2 years, we can directly go ahead with an ICL. If the patient is having progressive cornea, the KC is not stable, first we do a TPRK with cross-linking. Then we wait for next 6 months to check for stable topography and refraction at the end of 6 months. If both are stable, then we plan an ICL. For the decentered cones, we first plan an intact or trek along with cross-linking. Then we wait for 6 more months to check for stability, and then we can go ahead with ICL. So these are some of the important considerations we need to keep in mind during planning. The refraction has to be done by two different optometrists and the doctor himself or herself. RGP trial plays a very crucial role. So we compare the preoperative CDVA with the RGP contact lens CDVA. If there is a gross discrepancy, then there is a very high likelihood that the post-operative visual quality will be poor, and the patient has to be counseled regarding the same. UBM or a gonioscopy examination is to be done to assess the angle status or to rule out any iris or ciliary body anomalies. One another factor which is very important is the internal anterior chamber depth. So we all know that in KC there is a progression, there is a protrusion of the central part of the cornea. So it gives a falsely high value of ACD. So in such case scenarios, open angles on the gonioscopy is a more important parameter to decide for ICL. At the end, patient counseling is extremely crucial. So, patient has to be explained about the general description of the procedure. She has to be given about the information, the risks, and the post-operative care has to be explained. So, to conclude, what was already known was that ICL is a safe and effective surgical option for visual rehabilitation in KC eyes, alleviating the need for spectacle or contact lens. What our study adds is that it gives a stepwise approach by providing an algorithm for ICL implantation, especially for the complex keratogonic eyes. Thank you.
Good, good.
How long was your study? How long was the follow-up?
Sir, we have follow up these patients for like 2 years, sir. Post ICL implantation. Yes.
And most of the ICLs were off-the-shelf ICLs, or you had to customize most of the ICLs? Because in these cases, I don't think you would be getting off-the-shelf ICLs, right?
No, sir. These were the normal ICLs only, which are commercially available.
You didn't have to customize any in spite of the high astigmatism.
Sir, after we did the intacts, so like the K values decreased a little bit, so we had to use the commercial only. We didn't need to customize it.
If you talk of cylindrical number,
Sorry,
the
sir?
choices for the cylindrical number, choices in ICL is very limited
Yes, sir.
compared to Indian versions. If you're
yes,
correcting
sir.
high astigmatism,
Yes, sir. Yes, sir.
6 diopter or 7 diopter, 8 diopter,
Yes, sir.
I think ICL.
It won't be available above 6 diopters of
Yeah.
cylinder. Yes. So
but
all our
Indian
patients.
version can be customized for
Yes,
that.
sir. Yes, sir. So IPCL can be customized, but
Yes.
in our study we had just included the ICL patients to make it uniform.
And do you felt any need of rotation afterwards? Sometime surprise you got the access or something?
Not in this cohort of patients, sir. We have other patients in which this happened, but not in this cohort of patients. Like those patients didn't had a follow-up of 2 years, so we hadn't included those.
So the,
But
the
yeah,
patients who had a rotation in the lens,
yes, sir.
were they excluded from the study right from the beginning because it was a
Sir,
retrospective study?
they had come on the follow-up, immediate follow-up, but they were not available for the subsequent visits, sir. So, like we actually could add the angle of post-operative vault in
Ritika?
these cases to check if the ACD. So I mentioned a slide where there was a pseudo high value of ACD for these kind of eyes. So we can add an angle of post-operative vault and we can correlate it with ACD, but that arm has not been included in this study.
In keratoconic patients, we haven't excluded any ICLs at this point of time because of pseudo high vault or because of rotations. So white to white which we get on topographies are always not reliable in keratoconic patients, especially those who have past history of allergies. So in this study, we have taken digital white to white into consideration, and also with that, we have taken sulcus to sulcus into consideration. So with that, the outcomes are more predictable, but only white to white.
I think so. That's more important. And getting an exact angle is also not that easy.
Yes, sir.
Where you have to implant it.
Yes,
but
sir.
that's a good try.
Yes, sir.
Thank you.
Thank you, sir.